Welcome to the Medical Advocacy Sexual Assault Response Workshop as part of the summit. My name is Rebecca Nichols. My pronouns are she, her, and hers. And I'm a consultant that works with organizations that are making the world a more just and safer place for all of us. I've been working with survivors of sexual and domestic violence for the last 25 years, and I currently work primarily with nonprofits that are serving survivors and other helping professionals to make sure that the work they are doing is based in a trauma-informed approach, an approach that's focused on equity and racial justice, and also one that is taking leadership values into account.
My name is Nicole Broder. My pronouns are she, her, or they, them. I am a sexual assault nurse examiner, or SANE, in the Portland and Vancouver area, and I'm also the SANE coordinator for the Oregon Sexual Assault Task Force, which is how I'm getting to work with Rebecca today. I also have a background as a sexual assault advocate in both the campus and community settings from before I went to nursing school. So thank you for joining us today. This project was supported by a grant that we received through OVW, so very grateful for their support in allowing us to put this on.
So during this workshop, we are going to be really focused on medical advocacy and kind of what happens when a survivor is choosing to go to the hospital after an assault. We want to make sure that advocates understand those options for survivors and understand both kind of the healthcare as well as the forensic options that they hold. We also want to make sure that advocates understand who does what during an exam. What's the role of an advocate? What's the role of a sexual assault nurse examiner? And also who else is going to be involved within the hospital. We're also going to share the laws and resources that are specific to Oregon, and these resources are often focused on patient rights. They might also be options for survivors to help pay for some of the expenses that may go along with the exam or any follow-up services that they receive. And then finally, we also want to talk about all of this within the context of being trauma-informed so that survivors receive the best kind of advocacy. During the recorded session, we are going to be talking a lot about the exam itself. And then during the live session later in August, we're going to be talking about advocacy from that trauma-informed approach, as well as how to mitigate vicarious trauma. And then, of course, we're going to answer your questions about this session too.
We do tend to use a lot of terms, and depending on your current familiarity with sexual assault advocacy response, you may be more or less familiar with some of these terms. So a few that we just want to go over and make sure that we're all on the same page on. A SANE or SAY is a sexual assault nurse examiner or sexual assault examiner. In the case of a SANE, that means that it's a registered nurse who has gone through specialized training in medical forensic care for sexual assault survivors. In the case of a sexual assault examiner, that's a healthcare professional who's gone through the same training but does not come from a nurse background. So that could be a physician assistant, a doctor, or another discipline. A safe kit is what we refer to when we're referring to the evidence, the physical evidence that's collected during a medical forensic exam. And it stands for a sexual assault forensic evidence kit. These are provided to healthcare facilities free of cost by the Oregon State Police Forensic Laboratory. And is a little manila envelope with some swabs, some envelopes, and some paperwork.
An outdated term that still is sometimes used is a rape kit. And so you might hear that mentioned at a hospital, but it's actually the safe kit is what that's referring to.
And then the SAVE Fund is the Sexual Assault Victims Emergency Medical Response Fund, which is a fund that's run through the Crime Victims and Survivors Services Division of the Oregon Department of Justice in order to make sure that survivors of a sexual assault have access to post-assault medical forensic care. Things like the SAVE Fund are available in every state in the US, but the details do differ slightly. So if you've done any advocacy or been involved in medical forensic work in other states, you may know of similar funds that are set up. But we'll talk a little bit about what the SAVE Fund, which is Oregon's version of this fund, specifically covers. And then finally, SAMS Track is the name for Oregon's Safe Kit Tracking System, which is pretty new. as of the time of this recording, which is in 2021. It's only been out for a year or two. It stands for a sexual assault management system, and it's a way for healthcare professionals, law enforcement officers, the crime lab, to all keep track of where a safe kit is in terms of being processed or where it's being stored and what has or has not been done to it. And that allows survivors to keep an eye on where their kit is at and just be more informed about the whole process.
So let's start with what is medical advocacy? So generally speaking, what medical advocacy is all about is working with the survivor and supporting them to get the most fair and sensitive treatment after an assault. And medical advocacy includes a couple of different things. The first one is, of course, medical treatment. If somebody goes to the emergency department, then the staff there is going to make sure that the person doesn't have any immediate or urgent injuries. They're going to talk to them about any kind of physical concerns they might have because of the assault. And it's really focused on just that healthcare piece of what, the physical safety and the physical health of that patient. Also, the survivor has access again to the safe kit, and as Nicole mentioned, that's the actual forensic evidence that is typically on the survivor's body, and we're going to talk about that in great detail. And so the survivor can actually choose if they want both of those things, if they just want the exam itself, and we're going to again talk about that in a moment. But just know that those could be, that medical advocacy itself could be either of those things or both of those things. One thing that's not on your slide, but to think about as advocates, is that there might be other reasons that a survivor needs medical advocacy that has nothing to do with the assault. And this is more focused on the long-term care that a survivor might receive. So we know that survivors of sexual violence can sometimes have a real hard time going to the doctor just because of their experience, their trauma history with that sexual assault. And so as an advocate, you might be actually talking with them about, a visit to the dentist, or if someone is pregnant, talking to them about what that birth process might be like and what additional support they may need because they're a survivor of sexual assault. So we're not going to talk about that during this recorded session at all, but I just wanted to mention that advocacy in the medical context is not just the exam, but it's actually something that a survivor may need for years to come after an assault. So this statement, the survivor's choices define the strategy, is actually something that I learned at an Oregon Sexual Assault Task Force training back in 2003. And it was on a banner on the wall of this training. And I obviously remembered it for all of these years because it just makes so much sense to me. And this is something that's guided me as an advocate ever since I first read it. So I wanted to really start with this idea. And this is so very true during medical advocacy because it's important to remember, usually when we go to a hospital or if we're receiving care, we just show up and the exam happens and these things, the steps are just taken, by the medical professionals. Within the context of medical advocacy, a survivor chooses the whole time what they want to receive. They can say no to anything. It's our job, both the advocate and the SANE, it's our jobs to really make sure survivors understand what choices they're making, the pros and cons, and it's really just our job to follow their lead. And so this is something that I wanted to start with because it's true of advocacy in any way, not just medical advocacy, but within the context of medical advocacy, we want to give as many choices as we can, and we want to really follow the lead of the person receiving the care, and make sure they know what we're asking of them, make sure they understand questions, and make sure that because they're receiving so much information, that we're really going at a slow pace and that we're really just checking in with them throughout the whole process. So we also want advocacy to be survivor-centered, and I know that as a field, as a movement, this is important to all of us. But I wanted to break it down a little bit because we often feel like, again, we've got a list of things we need to do. We have a list of topics we want to cover, but we really just need to slow all of it down and focus on what the survivor is telling us or showing us. And so when our advocacy is survivor-centered, when we're giving those choices and taking the pace of the survivor, then that survivor is hopefully feeling more empowered. Obviously, after a sexual assault, there's such a lack of, there's such a piece of it that the power was taken from this person in such an intimate, physical way. And so when we're survivor-centered and we're really just letting them kind of tell us what they need, then we're hopefully giving them a lot of empowerment. I keep talking about the piece. And so survivor-centered advocacy, it gives time, it gives consideration. And in my experience, doing hospital response, survivors don't know what to expect. They're often very much in somewhat of a daze, that they're just trying to get through this experience that's very unpleasant or can feel very unpleasant. And so when we're just slowing down and checking in a lot, then hopefully that's just feeling a little more emotionally safe for that survivor. And when we are giving choices and we're following their lead, that's going to help them heal from this process. As you can imagine, obviously a sexual assault is very traumatic, and then medical advocacy can feel just like almost like an extension of that experience. And so when we are able to again just really follow the lead of the survivor, then they're going to have a different kind of experience with that. I also think that, especially in an emergency department, things move very quickly. There's a lot of people working really hard, especially right now as we're, still dealing with the pandemic. And so it's just a very fast-paced atmosphere, and it can seem very chaotic when you're not used to it. And so when we're survivor-centered and we're checking in a lot, then the people around us are usually mimicking that too. Advocates and SANES can create a really beautiful partnership by doing this, because it does really, everyone around us will do the same. In my experience, luckily, when I showed up to a hospital, the staff, the emergency department staff has also been like, oh, thank goodness, because they understand the survivor needs that emotional care and support, and they don't have a lot of time to give it. So it's our job to really do that and to really just stay centered on that. So I know that a lot of programs throughout Oregon are dual programs. In fact, Oregon only has 2 standalone sexual assault programs where their mission is 100% focused on sexual violence response and prevention. So I did want to take a little time to talk about how are these two types of violence different from one another. And so obviously within domestic violence, there's a familial relationship, there's typically an intimate partner relationship. But with sexual violence, we know that, most survivors, more than 70% of survivors, know the person who assaulted them, but it could be an acquaintance, a coworker, it could be someone they're dating, it could be their partner, but the kind of relationship is really, really different. So for example, if a person is assaulted by an acquaintance, they're not going to have a lot of details. They're not going to know if that person is HIV positive or not, probably. They're not going to know the sexual history of that person, or if there's any, concerns about sexually transmitted infections. So because those relationships really look different, a survivor sometimes doesn't have information that feels very important to them. Obviously, if they, something like HIV status is really critical. So we have to kind of take that kind of relationship into account. It also really comes up around our safety planning. So when somebody lives with someone who has harmed them or assaulted them, then we kind of can narrow down a lot of specific safety planning. If somebody is an acquaintance, maybe the survivor doesn't know where they live, doesn't know what their car looks like, all these sorts of things. It just makes safety planning a little more complex or different. And so it's something for us to keep in mind as advocates. The point in the middle here kind of speaks to the same thing, that, sometimes the survivor knows very, very little about the person who assaulted them. And in some ways that can actually feel more concerning to the survivor, because not knowing means that they can imagine the worst, and they're just not really sure. And so I think that is an important part of how we can support survivors and show up for them. The third point on this slide is really important. The truth is it's awkward to talk about sex. It's awkward to talk about body parts. Some of the questions that might come up during an exam can feel so very direct and personal. And for advocates, it can be really hard to sit with somebody, if we're not used to talking about those things, then we have to pretend we're okay with it when we're supporting a survivor. And that's kind of easier to say than to do. And so I really encourage advocates who are newer to this type of advocacy to practice, to just get comfortable with talking about these things, and to be prepared to talk about the kind of sexual component of this type of an assault. And the other thing that we already do as advocates is we often mirror the language that a survivor is using. And so that's something that I would do within medical advocacy. So if a survivor uses a certain word for a body part, then I'm probably going to use that word too. If they use a word that I don't know what they mean, I'm going to clarify. When I have, asked questions or talked about body parts or anything like that, I use the specific name. I don't use a slang term. I would just use the exact name for that body part. But then if the survivor was using a slang term or something like that, I would clarify that's what they meant, and then I might use it too. So just being prepared for that piece of this kind of advocacy, doing a little bit of practice. When in doubt, fake it till you make it. Again, just doing your best to stay centered and stay focused on the words the survivor is using, and making sure that our discomfort with these conversations is not impacting them, and we're really keeping that pretty internal. This is a great thing that you can talk with a supervisor about or a coworker about to just, again, kind of practice and get a little more comfortable with these conversations.
And one other option is that you can make use of one of the other pre-recorded sessions in the summit, which is called How to Talk About Sex with Survivors, which also has a workshop component. So that's another great place to get some advice on how to do that comfortably and get some practice too, if that's something that would help you out.
So the other things that we thought of here around the difference between sexual and domestic violence advocacy is the fact that, when what I know about the legal system is what I watch on CSI, it means that I have a pretty inaccurate understanding of what's going to happen. And so that happens for survivors too. If a survivor expects that they're going to report to the police and then the person will be arrested and then they'll go to court, there's just, because that's what happens on the TV shows, then that leads to confusion because it doesn't work like that. Things don't get resolved that quickly. There's all kinds of twists and turns that might happen that might be, not what the survivor is hoping for. And so one of the things to be prepared for is just to be able to say what you don't know. Like if you can't answer a specific question about what happens next, or if I report, will this happen, then just go ahead, first of all, admit what you don't know, and you could offer to follow up. But I think what's most important is that we understand that people might have a perspective of the legal system that's just not accurate. And it's really just our job to answer the questions we can, to follow up with what we don't know, and to make sure that things feel clear to the survivor. And then the final thing I wanted to mention is this victim blaming piece. And, of course, when we're supporting survivors of domestic violence, there's definitely victim blaming there too. But what is a little different about sexual assault is that in my experience working with survivors, they expect to be blamed because our culture sets the blame up in that way. So questions about the choices the survivor made before the assault, whether they were drinking or using any substances, their previous relationship with this person, all those things start to become part of these conversations. And so there's a lot that we can do as advocates to redirect anything we hear a survivor blaming themselves for, so that they can remember that nothing they did did they deserve sexual violence because of. The other thing that comes up within medical advocacy, and I've seen this more for survivors who don't know if they want to report to law enforcement, or they're still deciding, they've decided they want to do an anonymous report, is that there can be this kind of subtle version of, if you don't report this to law enforcement, then this person might do it again. And that's the most common statement that I've had to interrupt within medical advocacy, because it's really, again, that's just not the responsibility of the survivor. And so it's just a matter of kind of reframing, restating, supporting their choices, letting them know that they can, an anonymous report allows them to make a choice about reporting to law enforcement in the future, and that if they just simply don't know, then that's okay for now. But I think one of the things we can do, even if we're not seeing a survivor blame themselves for what happened, is just to remind them that they didn't deserve it. Nothing they did should have resulted in anything like sexual violence, and that it's really never their fault. And that when we talk about the follow-up advocacy that our programs offer, that's where they can keep getting that support after the exams happened. So when we think about what are the different options, so thinking about, let's say that a survivor calls one of our crisis lines or helplines, when we just think about what are all the different things that a survivor can choose immediately after an assault, and we're going to talk about these things throughout the presentation. The first one is whether they want to receive medical care, which includes things like pregnancy prevention or sexually transmitted infection testing. And so just really putting that out there, this is what could happen if you go to the hospital. They're going to offer you a wellness exam. They're going to offer you a forensic evidence kit. They're going to offer you pregnancy prophylactics or testing, and just letting them know that they've got, that's kind of what they can expect. And then also reminding them that they get to decide along the way what happens. The forensic exam, one of the things that I so appreciate about SANES is that they usually will describe the exam, at the beginning of the visit. They might describe the exam and what the survivor is going to be able to decide along the way, and they'll get a sense of what the survivor is thinking they want to do then, but then they'll keep asking and keep checking in. And so if you're talking with somebody on a crisis line about, what happens when I go to the hospital, I think what's really important is that reminding them that they can decide along the way. And so when a survivor is thinking about getting that medical care, then just reminding them that that's kind of up to them, and they have lots of options and they don't have to know right off the bat what they want to do. Reporting to law enforcement versus making an anonymous report. We're very lucky in Oregon that we have this option for anonymous reporting. And survivors actually have 60 years to determine if they want to identify themselves and link themselves to an anonymous report. So basically what happens is they can get the exam, they can get the safe kit, and they get, their safe kit has a number attached to it. And so that number goes with the kit to the crime lab, and they can decide for, they have 60 years to decide whether they want to say, hey, that number is me, and I want to do something with this. I want you to report this to law enforcement. And some survivors know immediately. They're ready to talk to law enforcement. They know they want that report made right away. If they decide to do the anonymous reporting route, then they won't even interact with law enforcement at the hospital. Law enforcement will come to pick up the kit, but they won't talk with the survivor. And so that's an important thing to decide, or excuse me, to know, is that it's really just, you can decide later. It's really hard to make these decisions so quickly right after an assault. So just kind of, it's just another option. Sometimes people just a survivor just wants to get the wellness exam. And that's also helpful if they decide to do it, to report to law enforcement in the future, because it just demonstrates that someone received care immediately because of sexual assault. So basically what I want to impart is that when immediately after someone has been assaulted, they don't have to make these decisions right away. That being said, some survivors just know immediately what they want to do. If someone reports to law enforcement, then they will be interviewed by a police officer as part of the evidence collection. And so that's something to keep in mind. So another option that survivors have are to apply to the crime victims compensation. And this is not something we put on your alphabet soup slide, but that's what CVC stands for, is Crime Victims Compensation. And we're going to talk about that towards the end of the presentation, but that actually is a financial fund that pays for some of the things after an assault, after any crime. So for a survivor of sexual violence, it might help them pay for follow-up therapy or changing locks on doors and whatnot. We're going to talk about that in a bit. And then finally, every survivor is hopefully also given the option of follow-up or ongoing services, and your programs may offer support groups. They may offer case management. They might offer legal support around navigating what comes next. But one of the things that I always want to make sure a survivor knows is that those things exist. It's not very common that a survivor at the hospital in that moment knows, oh yes, I'm going to do a support group. I want to call tomorrow and sign up. That usually isn't how it works. Just because they're absorbing so much information and still, having that acute trauma experience. So that's just something to say as many times as you can to make sure that when they walk out the door of the hospital, they have the phone number to your crisis line and they know that those services are available to them and exist. The nice thing usually about those services is they have no time connection to it, which is very different than all the things that are going to happen within a wellness exam or a forensic exam. So they could decide in 2 years that they want to come to a support group. They could decide in 6 months that they want to talk with an advocate about case management. But those options are available to them, and that they don't have to go through the healing process alone. And so just being able to describe those services, let them know how they can find them after the exam is really important. So during our live session later in August, we're going to be talking about these more in depth. But the basic gist right now is that what our job is to do is to support the choices that a survivor makes along the way. And part of that support is making sure they understand those choices, asking clarifying questions, just asking, does that make sense? Do you want me to say that in a different way? And just really picking up on whether or not they're following through with all this information that they're receiving. I think too, and we do this as advocates anyway, but asking questions that are really open-ended, that really just let a survivor talk through what they're thinking. And so then as an advocate, we can say, oh, I heard you talk about that this piece feels really important to you, and this is something you want to make sure you tell the same later. There are times where an advocate and the survivor are alone in the exam room, so there might be things that a survivor says to you that they haven't said to the same. In those moments, you could say, do you want me to remind you to tell the same that? Is that something you want to share with them? But again, just really asking those questions and giving space. Sometimes I've worked with survivors who just wanted to be distracted during those moments when we were alone in an exam room. And so you're really, again, just following the lead, and you're coming with all your bags, your big bag of ideas of how you can kind of be in the moment with the survivor and help them pass the time during that exam. And then again, so important to make sure they know that follow-up services are available, that the advocacy doesn't just live at the hospital, but is in the community and available to them after the fact, and that they can have that support as long as they need it. And one of the things that, having worked on crisis lines quite a lot, one of the things that I know is that the way that we show up for survivors when we're the first person or one of the first people that they're telling their story to really changes how much they want to tell their story again. So when we are supportive and we're compassionate and we're slow and kind, then they can feel really comfortable sharing what they need. And so they're going to be more likely to share what they need later, as with follow-up services after the fact. So that's really important to remember, that as much as we can be present in the moment, it's going to increase the likelihood that they're going to keep asking for support, even if it's from their friends and family. So that's really important.
I'm going to start talking a little bit more about what the healthcare aspect looks like. Again, this might be a reminder for folks who were engaging with the healthcare system a lot and then have found that services were suspended during the COVID-19 pandemic or otherwise altered. Or for folks who have never had a chance to do hospital response, either because of numbers in your community or because of the pandemic. Hopefully this will kind of acquaint you with the healthcare process and make you feel more comfortable being part of it as an advocate, or also helping to guide a patient through it or give them an idea of what their options are. I also want to make a mention of some of the language that I'll be using because I am a sexual assault nurse and I am seeing survivors of sexual assault in the context of being a healthcare professional and then being my patient. You'll hear me refer to survivors by and large as patients because that's how I'm seeing them. I recognize that advocates often refer to them as survivors or clients, and sometimes, depending on the context, I may use that language as well. I also want to touch on one more term, which is victim. In general, I try to stay away from that term because most survivors and patients that I've worked with don't prefer that. However, because I will be talking a little bit about some of the legal options available to these patients / survivors because of their legal status as a victim of a crime, you may hear me use that term, and I just want to call that out and point out that it's not meant as a judgment or any sort of derogatory term, but really meant in a legal context. So with that said, sexual assault survivors connect with healthcare in a few different ways. Most commonly, what we find, both in Oregon and across the country, is that a survivor of a sexual assault will come into the emergency department And that could be immediately after an assault or sometime later with medical concerns. Might be a concern about pregnancy or sexually transmitted infections. They may know that they want evidence collected or be worried about wounds. And an emergency department is oftentimes where they enter the healthcare system. However, that's not the only way that survivors will interact with healthcare. Inpatient refers to patients who are in the hospital for something that is leading to a hospital stay. Maybe they've had a surgery or maybe they're in for a chronic condition. And we do find that sometimes patients who are in the hospital for an extended period of time will disclose that they had a sexual assault in their past and are then given the option to work with a SANE, especially depending on how recently that assault may have occurred. So that looks a little different than the emergency department because that patient is staying in the healthcare facility for a longer period of time, rather than the emergency department tends to have a lot of flow in and out. And then a clinic is also an option that we see fairly commonly, where a patient may feel comfortable disclosing to a primary care provider or a clinic that they have been seen at before that they experienced an assault and may access medical services that way. So that's all for survivors who come directly to healthcare. Now, of course, some survivors come to healthcare through other agencies, such as a law enforcement agency. If they know that they want to report the sexual assault, they may go to police first, and then police may let them know that healthcare is an option, or advocacy agencies, especially if survivors already have contact with an advocacy agency through some other past concerns that they were working through or past connections. We often see referrals through that advocacy agency. And it's oftentimes easier to find information on sexual assault advocacy services in your community than it is to find information about SANE services. So we also see that with folks who haven't interacted with an advocacy agency before. They may feel more comfortable reaching out there first and then seeking out medical care from there. And that's really the impetus for most of the rest of this presentation, which is I don't expect to make you as a sexual assault advocate into a SANE. That's not your role. That's not what you went to school for. That's not what you've gone through training for. But because you might be accessed before the healthcare system, I do want you to have some familiarity with what processes may look like, and also how some of the options present for survivors, so that if they are seeing you first, you have some comfort level discussing that with them. So first, a little bit about SANEs, in case you haven't had a chance to work with them, or maybe you have and just sort of entities who wandered in and wandered out. So SANEs, like I mentioned, they're sexual assault nurse examiners. And this means that they are a registered nurse. They can be a registered nurse in Oregon if you're seeing them in Oregon, or if you happen to see folks in other bordering states, they may also be a registered nurse from those states. And typically those nurses need to have 2 years of experience with their licensure as a registered nurse before they can then go through SANE training. We require that because the forensic piece is complicated and nuanced, and we really want to make sure that those nurses feel comfortable in kind of the basic role of a nurse before they add on that medical forensic post-sexual assault piece. So those SANEs will have at least 2 years of experience, many times more. To be completely honest, forensic nursing and sexual assault nursing is still a fairly new specialty. I think it was only identified by the American Nurses Association in the 1990s. And so many nurses don't actually realize that this is a specialty that is available for them. So we also see SANEs who come from decades of experience sometimes, and then find this and work their way into the specialty in particular. After the 2 years of experience, they do need to go through a 40-hour didactic or classroom training, kind of similar to what most advocates go through as well. And that training will cover things like sexual assault dynamics, the neurobiology of trauma. It'll go through genital anatomy and physiology in much more depth and detail than most nursing programs go through it. It'll go through how to collect evidence, how to document wounds, how to assess for strangulation, how to assess for sexually transmitted infection risk or HIV risk, and all those different aspects that we'll talk about here. So they go through that 40-hour training, and then there are some follow-up clinical pieces so that the SANES can learn the hands-on skills as well. And typically those practical hands-on skills are how to insert a speculum, because many nurses are not trained in that through their nursing school. So speculum is that little like kind of duckbill instrument that you may have experienced in a pap smear. So they need to get trained in those. We want them to feel very comfortable using a speculum on a non-acutely traumatized patient before they then incorporate that into an exam of a patient post-sexual assault. And then the other piece is that they need practice doing the actual sexual assault medical forensic exams. And so SANES in training need to connect with more experienced SANES who can then guide them through that process and build up their skills and competency before they start working independently. Now, SANES work in a few different ways in Oregon and actually across the country too, because it is such a new specialty. The organization of SANE programs in different areas of the state and in different communities can vary significantly. But some of the main organizational structures are an agency structure is one. So in that case, SANES who work at multiple different healthcare facilities may all be part of a separate SANE agency or group that then disperses those SANES amongst a group of hospitals. So each hospital in that case is not responsible for providing their own SANES, but kind of share a pool of SANES who are trained. So that we have that mostly up in the Portland, Vancouver area, kind of down through Salem, in Central Oregon, and in Southern Oregon currently is where that model tends to be as of 2021. Kind of another common model after that is for each hospital to try to maintain its own group of SANES. Now, for hospitals that have good funding and robust staffing, that may not be super difficult. And so they may be able to train up and keep trained a group of SANES to respond to sexual assault patients who present at their facility. We do know, however, that especially if you're in a rural community or just a community that's more isolated or smaller in general, that can be difficult for hospitals to get enough SANES in the first place or train them up adequately or keep up their competencies. And so those programs we tend to see kind of ebb and flow a little bit more. And that's something that you may then kind of see some ripple effects from in your advocacy work. So I just wanted you to be aware of why that may be. And then another organizational structure that is common in some areas of the United States, but very uncommon in Oregon currently, is to have a standalone SANE clinic, which is something that is either separate from or kind of detached from the hospital. It's not in an ER, it's not in inpatient patient rooms, but more of a clinic setting that specifically is geared to see sexual assault patients. And so even though it is less common in the state, it's my favorite kind, honestly, because you get to really gear that whole space and everyone working in that environment towards this specific need. There are other options like telesane and things like that, but those three structures are kind of the main ones that we currently see in the state. So before a SANE gets there, I just want to touch on some of the healthcare aspects that either a patient may have gone through before you get to see them, or what you may be accompanying a patient through. So every patient who comes into the hospital has to be checked in. If they're inpatient and they're, on a unit somewhere, that will probably have happened before the sexual assault disclosure occurred. In the ER, that happens, right there before they're let back to a room. But the check-in process just establishes that they're at the hospital and kind of gets them into the chart and gets those formal processes started. There's also the triage process, especially in an emergency environment, where healthcare professionals will take that patient's vital signs and talk to them about what brought them in that day. And triage specifically refers to the fact that based on those vital signs and their reason for coming in, they may be prioritized as more or less urgent based on whether they need or may need like life-saving care, or whether there's something time sensitive to their visit. So typically, unless there's serious wounds that a patient presents with, sexual assault is often triaged fairly high priority, but not the highest. So patients who are at risk of bleeding out imminently or have had a stroke or heart attack, really serious medical issues like that, will be prioritized above most sexual assault patients. Again, unless there's serious wounds that that patient has endured themselves. But because, we recognize that sexual assault is a very traumatizing experience, and because of the time-sensitive nature of getting certain medical interventions on board and collecting evidence, if the patient wants either or both of those things, is still prioritized quite high. So just something for you to be aware of. Now, depending on the facility and how busy it is, that could still end up with a wait, but we've really impressed on hospitals that getting these patients into a private and quiet, if possible, and comfortable spot is really important. Now, the medical screening exam will typically happen before a SANE arrives, and this is just a term, it's also called the MSE, more alphabet soup for you. And all this means is that a provider, so a doctor, nurse practitioner, physician assistant, will just come in briefly and make sure that the patient is not in imminent physical danger. So typically that means, okay, they are breathing well, they don't have any active bleeding, there's nothing that's a super urgent concern that could threaten life or limb or health. Now, if that medical screening exam or if the triage process did uncover something that is very immediately concerning, such as bleeding, such as broken bones, things like that, then the patient is going to be medically stabilized. And this will typically happen before the SANE gets there, because as important as the sexual assault medical forensic exam is, keeping that patient alive is far more important. So if a SANE's already there, may be able to work with the team and start doing some medical forensics while the stabilization is occurring. But the stabilization of the patient really takes priority to make sure that that patient is as healthy as can be and not in imminent danger. Now, depending on what kind of SANE program the facility uses, there may then be a period of time of waiting for a SANE nurse. Because sexual assault patients don't show up on any sort of regular schedule, most hospitals do not have SANEs on the hospital grounds at all times. It's just not feasible. Now, depending on staffing, they may have SANEs working in the ER that they can pass on their patients to someone else and then have them switch over into their SANE role. But oftentimes a hospital will have to call a SANE to come in for the exam. And that could take half an hour if you're in a metro area, or it could take longer if we're dealing with larger distances and more isolated facilities. Please do know SANE programs do try to make that time as quick as possible. And again, just because there's not necessarily an on-site SANE at all times, there's typically some sort of waiting period. Now that's where I really love if you, the advocate, has already had the chance to come in because then you can be there with the patient. You can start, with any crisis intervention you need to do. You can start building that rapport with them. Maybe even working on some of their discharge concerns or follow-up concerns that you're able to help with. That can make it a really nice transition into the SANE exam. But I also recognize, depending on where you are and just the specific circumstances of that day, timing can be a little all over the place with these.
Ideally, best practice is that the advocate is dispatched, just as quickly as the SANE and is there before the exam starts. And so it's a great idea if you are on call that you are ready to go, that you have snacks and water and comfortable clothes. I've done things like, make sure I didn't have jewelry on, just simple things because maybe the survivor wants to hold my hand and squeeze it, those sorts of things. So, so being ready to go as quickly as possible is really important. But obviously, when you first show up, a survivor may not know what your role is, and so you also should be ready to describe what you're there to do. Some survivors will hear that and decide they don't want an advocate present. So that's okay. You will hopefully just leave that crisis line number and let them know how they can reach your program afterwards. But being ready to make sure you can stay there for a period of time and then be ready to describe what you're there to do and provide. There have been times where a patient was sleeping when I first got there and the SANE hadn't arrived, so then I'm just going to sit in the waiting room and wait until everyone is there. So just be ready to wait. Do your best to be as comfortable as possible and make sure that you have the materials you need.
And the other aspect of that is, kind of self-care and boundaries and sustainability is conversation we'll get more into in the workshop portion. But one of the only negative experiences that I've had as a SANE with an advocate was when an advocate showed up for one of my patients, but the advocate had a final in the morning and it was late at night. And so the advocate showed up and immediately told the patient that they couldn't stay very long. That definitely interfered with the rapport that the advocate was building with the patient. And so just a reminder that, those things are important, and make sure that you're able to carve out the time and space to respond if you have agreed to respond to the hospital. So there are several different medical options that are available to survivors of sexual assault when they arrive in a healthcare environment. And one thing I'm going to stress now and continue stressing is that, as Rebecca mentioned, everything is based on what the patient wants. And so, even as I go through these options, it's not like, you're choosing one off a menu and you get what you get. It's more that this kind of describes a spectrum of medical care that's available to the patient. And they're able to say both at the beginning of the exam and during the exam how they want that spectrum modified for their own needs to make sure that we're doing the best job we can for that patient. But the kind of spectrum, as I tend to conceptualize it, runs from, on the one hand, you could do a wellness check, or SANEs could do a wellness check. What this refers to is typically if a sexual assault survivor doesn't really want like the forensic part of the exam. They don't necessarily want their body assessed or wounds documented or evidence collected, but they just want to know if there's anything immediately dangerous going on with their health as a result of the assault. And so SANEs can absolutely do, just that wellness check, talk with them about any specific medical concerns they have, respond to those. And if that's all the patient wants to do, that's all that they should do. What may be added on to that, or what patients may choose instead, is to really focus on prophylactic or preventative medications. And these are typically available for pregnancy, for sexually transmitted infections, and for HIV. And we'll talk about that a little bit more later. But the one thing that I want to highlight here is that for these preventative medications to be the most effective, they typically need to be given within a certain amount of time, which differs by medication. But emergency contraception is often available to prevent pregnancy up to 5 days after an exposure. HIV preventative medication is typically available up to 3 days after an exposure. So it varies, but it tends to be in that like 3 to 5 day window for most of these. So again, if the patient really is just worried about, hey, I don't want to get pregnant, if that's an option for them, or I'm just really worried about getting an STD or STI, that can also be the focus of the visit, and it doesn't necessarily have to go beyond that unless the patient wants it to. Now, we're saying spend more of their time is in what we call a partial exam or a complete exam. And all that partial exam means is that evidence was not collected, but the rest of the medical forensic exam process was done. And I'll go through kind of the steps of what that exam is in a little bit here as well. But partial exam, no evidence collected. Complete exam tends to mean that some sort of physical evidence was collected. There are a whole variety of types of physical evidence that SANES could collect. Again, we'll get into that a little bit more here shortly. But usually physical evidence is an option for patients within about 5 days of the assault. Ultimately, it's up to the discretion of the SANE, who can absolutely, talk with the patient and determine that there may be a reason to collect evidence beyond that time frame. But in general, physical evidence will be off of the patient's body and no longer able to be collected after or by the 5-day mark. A few things that sometimes patients want to have as an option that are simply just not an option with a SANE is determining whether a sexual assault did or did not occur. Most often, this is in the context of memory loss, where the patient may not remember a period of time, may have woken up feeling sore or naked or with their clothes in disarray, or something that makes them concerned that while they were not retaining memories that a sexual assault occurred. That is not possible for a SANE to determine with any certainty, especially at the time of the exam. Now, what the SANE can do and should offer to the patient as an option is to do any physical exam that the patient is comfortable with, perhaps collect evidence just in case, again, if the patient wants that, and to share whatever findings they see on the patient's body with the patient. And the patient can then determine, based on whether those findings are surprising to them or unknown or new, they may make up their own decision about what did or did not happen. But there's no physical finding that can just tell us saying, oh, this patient was sexually assaulted. Just as there's no physical finding that can tell us saying this patient was definitely not physically or sexually assaulted. But again, they can share their findings with the patient, which then may give the patient more information and feel more power over their situation. The other option is if the SANE is collecting evidence, there is the possibility that if the patient chooses to have it sent to the crime lab and tested, that someone's DNA or semen or vaginal fluids may be found on them in a suspicious area that, again, makes it likely that an assault occurred, but again, can't determine for sure. But that will not be available at the time of the exam. That's a much lengthier process. So all that to say that if a patient really just wants to know, or I should say in this case, if a survivor really just wants to know, was I raped or not? That's not something that the hospital is going to be able to answer for them with any certainty. The other thing that is impossible to determine with certainty at the time of the exam is determining whether a patient was or was not drugged. So drug-facilitated sexual assault, or we call it DFSA if you want to keep going with the alphabet soup, is something that we do see pretty frequently. And all it means is that the assailant used alcohol or drugs, which could be over-the-counter drugs, prescription drugs, illegal drugs, you name it, in order to make the assault possible. Now, what is an option for the patient is that the SANE could collect blood and urine, which could be sent to the crime lab and tested for something like 200 plus different substances. Couple limitations. A, just like with the other evidence, that won't be available at the time of this patient's visit. It will take some time to get those results back. So it's not a quick answer. And then the other kind of caveat to that is that different drugs leave the patient's system at different rates. Some, especially like sleep aids, may stick around for days. Other substances like date rape drugs may be out of the patient's body within hours. And so there may be the possibility that the crime lab may detect a substance that the patient knows they did not ingest willingly and be able to point that patient in the direction of you were likely drugged. But if that test comes back negative, there's no way to tell for sure whether a drug may have just been metabolized by the patient's system already and therefore undetectable or not. So again, it's not like either of these things are just completely lost causes. It's more that if the patient comes in with a very specific expectation or need to have a question in their mind answered, this may not satisfy those needs, but it can give them more information and help them with their overall sense of agency over what's going on. A few notes also about age that I just want to touch on. The vast majority of our SANEs in the state of Oregon work with adults and adolescents, typically down to about 15 years of age. But I would recommend, if you don't already know what ages are seen at your local healthcare facility, that may be a little homework for you to do, just so that you are more aware of it. We don't have many pediatric SANEs in the state of Oregon currently. We're trying to change that. We're working with folks in the child abuse community to kind of increase that response. But a few things that you should know about age. Anyone 15 years and above can consent to medical services or decline medical services. And this would include a safe exam and a safe kit. So what that means is anyone who an adult adolescent SANE is typically seeing, 15 years and above, can determine for themselves whether or not they want to work with the SANE. And if they do work with the SANE, what parts of the exam they want to have or not have. That also means that no one can legally pressure them into it. So a parent can't decide on behalf of a 17-year-old that, no, you're going to get this exam. That 17-year-old gets to decide for themselves. Social pressure, that's a different thing. Can't avoid that entirely. But from a legal standpoint, no parent or adult can require a 15-year-old or older to go through this exam or to not go through the exam. Now, for patients 14 years and above, they're able to consent to psychiatric and chemical dependency treatment if that's something that they need or want. And then any age can consent to birth control, both receiving information on it and their different options, and also actually accessing it, which means that as we talk about the preventative medications for pregnancy, that's something that is available to all patients who are seeking healthcare. Ooh, I need some water. So just to go a little bit more in depth into some of these medical options, a wellness check, again, it's not a full medical forensic exam, but some of the things that might be available to the patient, depending on their needs and their wants, would be having any injuries assessed or treated, talking about risks for either complications from a wound or maybe elevation of a disease process, or diseases such as sexually transmitted infections or HIV or risk for pregnancy, and then being able to have that assessed by the SANE with referrals as needed. It can also just take care of immediate physical comfort and immediate physical needs like pain or nausea. That also falls under a wellness check, and then any other concerns that the patient is having, which can vary significantly based on the individual patient and the individual circumstance. With the prophylactic or preventative medications, these are the three different categories that I mentioned, but let's go into them in a little bit more depth. So any sexual assault patient who currently has a uterus should be screened for risk for pregnancy. Now, that can be difficult sometimes, especially when we have patients who are trans men who may have a complicated relationship with their uterus, depending on their specifics of their gender identity, any body dysmorphia changes that they want to make or not make. But any patient with a uterus should absolutely be assessed for pregnancy risk because hormones like testosterone or other things do not count as an emergency contraceptive and will not reliably keep the patient from getting pregnant after an assault. So pregnancy is something that we really try to make sure that we cover for anyone with a uterus and anyone, almost any age too. Even patients who haven't yet gone through puberty, although that age gets lower and lower, even patients who haven't gone through puberty yet may be right on the cusp of having their first period, and so could actually be at risk of getting pregnant. It's kind of err typically on the side of assuming pregnancy is possible. On the other side of things too, we do see some older women or even just women whose periods have not, what am I trying to say? And on the other side of things too, we'll have women come in, often older women, who say that they are postmenopausal and that they no longer get periods. But what we found is sometimes they are truly postmenopausal. And sometimes their periods have just become so irregular and so infrequent that they're not truly in menopause yet. And so, unless they really have not had any sign of a period for several years, that may be another case where the SANE may want to talk with the patient about maybe taking a one-time emergency contraceptive instead of taking the risk that maybe they are still ovulating occasionally and so may at times be at risk of getting pregnant. Now, the pregnancy prophylactics or preventatives are called emergency contraception. There are a few different types. You don't need to know all the details, but what I do want you to know is that they're not an abortion pill. And I find this really important because I've had several patients come in who absolutely do not want to have any sort of abortion, but are okay with emergency contraception because once it's explained how the two things are different. And so to make sure that the patient really is informed, I just like folks to know that there's a difference out there. So with emergency contraception, all of that means is that a pregnancy is kept from starting. So if the patient is already pregnant, it's not going to change anything, but it will prevent those initial pregnancy processes from occurring, that initial fertilization. Oftentimes patients are comfortable with that, even if they're not comfortable with other measures to end a pregnancy. Now with STDs, sexually transmitted diseases, and STIs, sexually transmitted infections, basically refers to the same thing. The medical community just used to use STDs a lot more. Now we use STIs a lot more. The main things that we can prevent with a one-time dose at the hospital are gonorrhea, chlamydia, trichomoniasis, and bacterial vaginosis. Again, I don't need to make you all into nurses who know all the ins and outs of those diseases. Also, I wouldn't wish some of the pictures that I've seen on you relating to those. But I do want you to know that those are fairly easy to stop with a one-time dose of antibiotics. And to cover those 4 different ones, it typically ends up being 3 different types of antibiotics. It's also typically a mix of pills and a shot. There are various options, though, available to the patient. So if they are unable to swallow pills or if they are uncomfortable getting a shot, please just know that they can absolutely discuss those concerns with the SANE and that there is likely a workaround that can be figured out. The other thing I want to mention in regards to this is that taking all those antibiotics at once, plus taking hormones, if they're also having an emergency contraceptive, can make patients feel really nauseated. So typically a SANE will also order them a pill that helps prevent nausea and vomiting, because it's of no use if they throw it up. And we also just don't want them to be in any more discomfort than they already are. Now, where it can get a little bit more complicated is with HIV. HIV, there are medications that can help prevent the transmission of HIV. They are more effective the earlier the medications are taken. They can't be taken any later than 72 hours after an assault. But unlike with gonorrhea, chlamydia, trichomoniasis, and bacterial vaginosis, the HIV preventatives are a month-long course, and it tends to be 2 different types of medications. So it's more involved, it's got more follow-up. I don't want any of that to mean, though, that a patient doesn't have the option to get those medications if they want them. It just means that it will take a little bit more in-depth conversation with the SANE, with the doctor who will be prescribing those medications, and just a little bit more follow-up commitment from that patient. But again, that conversation is not something that's on your shoulders. I just want you to be aware that it's something that they may end up having to talk more about with the SANE and the doctor.
Maybe one thing that as advocates you can remember, because this is something that has overwhelmed me during an exam, is I can't possibly know the details, but I could say to the provider, could you explain some of the if there's any potential follow-up or any potential side effects? So rather than trying to remember those details, just maybe prompting the question, because I have been in scenarios where a provider suggested HIV prophylactics, but didn't mention that it was a month-long process or something like that. And so,
that's important.
Yeah, it's important. So of course the survivor does not want to get HIV. They want to say, yes, I want that, but just to say, maybe before the survivor decides, could you just explain what that looks like how long this is take, what are the potential side effects, or what can they expect? So just asking that question can be helpful.
That's a really good point, and also a really good reminder to me to also mention that depending on how often you end up responding to the hospital, you may end up kind of on the opposite side of what Rebecca was talking about. You may end up picking up some just like medical knowledge from overhearing things. And I would say still default to what Rebecca mentioned. Keep it broad, advance the conversation rather than trying to take that on in your own wheelhouse or develop expertise in that area. You are the advocate for a reason, and you do a really important job for the patient, and that shouldn't overlap with you then trying to give them medical advice either. So prompting more conversation, asking more questions to elicit more information is a great thing to do on behalf of your patient. And don't feel the pressure or really just, don't put it on yourself to actually learn a bunch of medical information and then feel like you have to advise the patient in that way or stay up to date on all those recommendations as they change. Go ahead and leave that to the medical folks. We get paid for that. So I mentioned this before, but I said I was going to keep mentioning it, and I will. Patients can accept or decline any portion of the medical forensic exam at any time. And what SANEs should be doing is letting them know this at the beginning of the exam, but then also bring it up with them frequently. And I will go through like the different steps available to the medical forensic exam in a second here. But I think it's really important for SANEs to remember the power differential that we have with patients. And again, this is an area where you may find that you have a chance to advocate for the patient or help bolster them in speaking up for themselves if a SANE happens to falter in this area. But even as a nurse, when I am in a medical environment, I have a hard time speaking up to my provider or my doctor if I'm not given an opening to do so. It's just hard to interrupt and stop someone from doing something that they're already starting. It is much easier to be asked my thoughts and then just share whether or not I'm comfortable with something going forward. So we really impress this on SANEs, and that should be a regular part of SANE practice. And so again, if you happen to catch a SANE on an off day or someone who's new and you're seeing that that's not happening, please feel free to advocate on behalf of your patient or just help them find their voice and speak up in that moment. But hopefully it shouldn't be on you. And for more on kind of power and hierarchical dynamics in the hospital, we also actually have another pre-recorded educational session on that SATF and OCADSFA are doing together on power and hierarchy in the healthcare environment. So if you want more on that topic, feel free to check that out. So there are a bunch of different ways that the medical forensic exam can be divided up. This is the way that works best in my brain. If you hear another kind of structure that works better for yours, please feel free to run with it. But this is the one that makes the most sense for me. So as Rebecca mentioned earlier, the first thing that a SANE is going to do on arriving at the facility or meeting with the patient is to introduce themselves, which maybe seems a little basic, but just like the importance of you introducing yourselves as the advocate and explaining their options with you, it's really important for the SANE to do the exact same thing. Most patients will have not gone through this process before, and most will have no idea what options are available to them. And many will come in with concerns about having their autonomy and their ability to choose taken away from them. So really important that SANEs start off with that. And then depending on what the patient wants to do in terms of the rest of the exam, there are consent forms and release of information forms, or ROIs, that the SANE will get signed to show that the patient is giving consent. And we'll look a little bit more at those later. But if a patient chooses to have every step done, this is typically what it will look like. First of all, the SANE will talk with the patient about what happened. And we call this the history. It's a sexual assault history if they're talking about the sexual assault, but it could also include any relevant medical history from the patient's past that may be relevant to the exam now. So maybe they're recently recovering from a broken bone, or maybe they recently had bottom surgery, or maybe they recently had a hysterectomy. All of those things and many more factors can then influence how the SANE is going to do the exam in the most informed and thorough and competent way. Oftentimes that history will start off broad, and then the SANE will follow up with any specific questions that they need. Just like with anything else, the patient gets to choose every part of this. So if there's a question that they don't want to answer, they should absolutely be free to make that decision. But that said, a thorough history will really help make sure that the rest of the exam is done as well as possible. So I also like patients to be aware of that so that they're truly making an informed decision about what to share or what not to share. Now, after all the kind of questions are asked and all those details are written down, which can be lengthy, especially because some of those questions are very personal and sometimes very vulnerable, that's typically when the SANE will start the physical exam if the patient wants. And that allows them to kind of build up rapport. But like I said, also, those details from the history will really help guide the physical exam as well. So that's why it's typically done in that order. Although this is a good time for me to mention too, if the patient really needs things to be done in a different order for their own comfort or just responding to other needs that they have, that's also something that a SANE can try to do on their behalf. Now with the,
sorry to interrupt you, Nicole. One thing I also want to say here in terms of the advocate is a survivor may change their mind throughout this process of when they would like the advocate to be in the room. So it's also a good idea for you to ask, so when physical exam starts to begin, if the patient is going to remove any clothing, obviously it's a good time to say, hey, I'm going to step out and give you some privacy, or would you like me to step out? But similarly to the SANE asking for, that permission or guidance along the way, advocates can really be doing the same thing.
That's a really good call. Thank you for reminding us about that. And as a SANE, I have definitely had patients who wanted the advocate there for every single one of these steps. I've had ones who wanted the advocate out of the room until it was the end and they want to talk about follow-up. And I've had everything in between, you know, some steps having them there, some steps not. So it's really important what Rebecca mentioned. Now, with the physical exam, because again, this can be something that feels very vulnerable and sometimes re-traumatizing for a patient, the SANE will typically start with the least invasive parts of the exam and then go more invasive. So typically what that means is that options for external body assessment, what we call a head-to-toe exam, because it's literally looking at every surface on the patient's body from head to toe, that's usually what the SANE will start off with. And again, you're going to get tired of me saying this if you're not already, but the patient gets to choose. So if the patient wants their right arm to be assessed, but not their left arm, if they want their upper body to be assessed, but not their lower body, any of those things, the SANE should be proactively offering those choices, checking in, and then respecting what the patient says. Now, if the patient knows that they want physical evidence collected, typically the easiest way for the SANE to do this, and also what's typically the easiest on the behalf of the patient as well, is to tie this in with the head-to-toe exam. So that as the SANE is looking at different body parts and assessing them and documenting in their chart, that they can also collect any physical evidence as needed. But again, we'll talk about the physical evidence bit in a little bit here. So external body parts, you know, trying to go like least invasive to more invasive, which also then means that with an anogenital exam, that if the patient is comfortable getting an anogenital exam, that typically takes place after the head-to-toe exam has already been completed. Again, giving the patient time to feel more at ease with the SANE, build up rapport, build up comfort, and keep it from being a re-traumatizing experience. And again, that can involve any parts of the anal or genital areas that the patient wants. And if the patient wants evidence collected, then that can also be incorporated into that exam process. Without getting too in the weeds, I do want you to be aware too that the anogenital exam also has a wide spectrum of how invasive it is. Typically, a good rule of thumb is that the less invasive the exam, the less assessment is going to be able to occur and the less evidence collected. And the more invasive the exam, the more evidence will be collected and the more thorough the assessment. And so patients should again be given the option by the SANE to choose where on that spectrum they feel most comfortable. Is it more important for them to not have re-traumatizing contact at their genitals, even if it means that maybe the evidence quality won't be as good? Or is it more important to them to have a really thorough assessment, to maybe get evidence collected, even knowing that that may be physically a more difficult or emotional process for them? So know that there's a whole variety of spectrums, and the SANE should be offering that to the patient.
One thing I'd love to say here too is that typically at this point in the exam, if the patient still wants me in the room, obviously I'm sitting by their head, at that end of the bed. I can't see anything that the SANE is reviewing, and I always offer my hand because, and I think almost every time I've offered it, it's been accepted as just a thing to kind of like squeeze onto, because this part can feel really difficult to get through, even not within a sexual assault forensic exam. This can be an unpleasant experience. So if that feels comfortable to you, to offer it, but definitely just make sure you're checking in and that you're where the survivor would like you to be.
That's a really good point. And it is, pretty nice. Well, taking that back. That's a really good point. Thank you. And on that note, the more flexible you can be too, the more that the patient is likely to find a solution where you are there in a way that is supportive to them without feeling, nope, still don't like the way I'm saying that. That's a great point. And I've seen a whole bunch of different varieties in how patients choose to have advocates at the bedside, if they do have them at the bedside during this. Like Rebecca mentioned, being at the head of the bed can often mean that there's, absolutely no line of sight to anything sensitive. Sometimes there are also curtains in hospital rooms. And so I've had patients ask for the advocate to stay as moral support, but be behind the curtain or maybe facing the wall. So sometimes it just involves a little bit of creativity, but you might be surprised at how often a patient actually does want the advocate there for parts of the exam that can feel, very, very vulnerable. And again, just being kind of flexible and finding a solution that works for the patient and prioritizes the patient's comfort is always the best way to go. God, that should not have taken me so many tries. Jesus. Thanks.
Beautiful.
It's the screen. I feel like I lose half my brain cells.
I'm sure it's weird. I miss people.
Yeah, exactly.
I don't know that you talked about the last piece there, the medications. Yeah.
You're right. Thank you. Oh my goodness. What would I do if you weren't here?
You would have been done 10 minutes ago.
Nope, not at all. This is great. So once the history has been done and the physical exam, then the SANE is really in the best position to talk to the patient about any risk factors for disease or injury complications or pregnancy that the patient may be worried about, and also in the best position to recommend any follow-up or referrals. So typically that's done at the very end so that the SANE is incorporating all of the knowledge that they have gathered over the course of this exam in order to really individualize their medication and referrals recommendations. Now, I do want to mention that SANEs, being nurses, do not actually prescribe medications. And so what will happen is the SANE will talk with the patient about what they're interested in, what their options are, but then relay that to the doctor or whatever provider is seeing the patient. And of course, that means that if the patient wants to talk directly with the provider about any of the options that the SANE is talking about, that's absolutely an option as well. But I just wanted you to be aware of why the doctor is most likely to come in at this point then. And another nurse may end up giving the medications depending on if the SANE is employed by the hospital or not. It can feel complicated, but they'll work it all out. Referrals too might include things like counseling. It could include things like HIV follow-up. Typically, pregnancy testing and sexually transmitted infections testing is recommended a couple of weeks after the visit, just to make sure that those preventative medications, if they were taken, worked. And if the patient didn't choose to take those medications, just to give them more information so that if they do end up pregnant or with an infection, that they can then have the options to deal with that however they would like to. So all of that is kind of taken care of at the end there. And typically at the end, after the SANE has done the whole exam, is when the provider or doctor will likely come in and see the patient briefly. Now, thank you, Burke. Now, what should not happen is that the doctor should not be coming in and repeating the medical forensic exam. The reason that they should come in after the SANE is that the SANE can then relay any outstanding concerns from the patient to the doctor, or relay anything concerning that they saw in their exam that was not within a nursing scope of practice to handle. And so they can then communicate that with the doctor and have them follow up as needed. So one of the goals of that is because doctors often don't have any specific medical forensic training and often don't have a lot of time available to really spend one-on-one with a patient, that the SANE is taking care of all that really specialized aspects of the exam. And then really just kind of minimizing the doctor's role to whatever is necessary that won't duplicate what's already been done, if that makes sense. It's all meant to make the patient's visit as efficient as possible and the least re-traumatizing as possible. Now, that said, this is also a good point for me to mention that this process can be quite lengthy, even in the best of situations. The fastest exam I've ever done, because my patient was specifically asking me to go as fast as possible, was 45 minutes. And that felt like a breakneck speed. And I spent another like hour and a half on my documentation because I was really just prioritizing what the patient was asking me to do, which was get her out the door. The lengthiest exam I've ever done personally was 9 hours. And it would have gone longer if I hadn't had a trainee with me who was helping me with some of the work, actually. It all depends on what exactly happened during the assault, what kind of risk factors are present, the state of mind of the patient, the needs of the patient, the wants of the patient, a whole host of different factors really go into that. I would say on average, I tend to see medical forensic exams take about 3 to 4 hours, start to finish, from when a SANE arrives to when the SANE is all done with their documentation and hands the kit over to police. Sometimes the patient can be discharged before the paperwork and stuff is done, but it's typically at least a few hours that the patient is there, and it may be much longer. So that's again where your role as an advocate is so important, because being able to make sure that the patient is able to speak up for any breaks that they need, or just help them be comfortable, makes a huge difference in what this experience is like for them, and whether those few hours feels like a huge obstacle or whether it feels like a step along the path to healing. And so, something that really stuck out to me when I went from being an advocate to being a SANE was how much time changed. My perception of time changed. I found it really challenging at first, honestly. And I found it challenging for a couple of reasons. Well, actually, it's kind of just one reason in a few different ways. The main challenge that I found was that as an advocate, I was able to devote my entire attention to the patient. And as a SANE, I was devoting my attention to the patient, and I also had a very detailed 16-page medical chart that I also needed to devote attention to in order to do my best job for the patient. Um, but switching my attention back and forth was kind of tough, and making sure that I was, thoughtfully considering all the different options for medical care, for forensic evidence collection. It is distracting, and it's distracting in a way that maximizes the care for the patient. It's still distracting. And so I was always really good at getting the patient a warm blanket if they didn't have one already, asking if they were hungry or thirsty. And we'll talk a little bit more about some of the options for that in a little bit too. But what I wasn't as good about was realizing that, hey, 45 minutes or an hour has passed, and that warm blanket isn't so warm anymore. Because in my head, when I'm going through the paperwork, that can feel like the blink of an eye. And so, every time an advocate mentioned like, hey, some time has passed, like, do you maybe need a break? Or you weren't hungry before, how are you feeling now? It wasn't like I didn't want to be following up with the patient on that. The advocate just had a much better sense of time and was also able to keep a closer eye on the patient and pick up on nonverbal cues too, that the patient may have a need that needed to be expressed. So that kind of collaboration can really, really elevate the patient experience in a way that I can't even fully describe, because those little things in terms of comfort and following up on needs just sends a really important message about how important that patient is and how they're being cared for.
I will say too, those I mentioned that there are moments where you might be alone in the exam room with the patient, and in my experience, that's often when we're waiting for the discharge to happen, and so those cues and being able to read when the patient is just done talking about what's happening in the moment and they want to be distracted or they want to close their eyes and have silence, that's all part of what you're there to do and to kind of pick up on. And the fact that you are being able to walk away and grab that next warm blanket, again, in my experience, hospital staff have been happy to let me go do that, and grateful. And so I really do think of myself as just, I'm just trying to make this as smooth and soft of a process as I can, knowing that it feels quite hard.
It's hugely important. So a little bit more on consent and on release of information that I want to touch on. Something that it's going to be very important for the SANE to do at the beginning of the exam and throughout the exam is assessing the patient's capacity to consent. As important as the medical forensic exam is, it's not saving the patient's life and it's not preserving the patient's limbs. Which means that it's really important that we are checking in and only doing what the patient wants us to do and checking where that limit is and not stepping over that, because that can be incredibly re-traumatizing for the patient, or just straight up traumatizing. Where that can get complicated is if the patient has experienced a drug-facilitated sexual assault, they may be still under the influence of alcohol or drugs. And so that is a fine line for the SANE to walk in terms of determining whether or not the patient is sober enough to consent. Typically, what that process will look like is the SANE will explain what the exam entails, kind of some basic risks versus benefits, and then see if the patient understands that and can express those things back to them. If they can't, then they're not truly understanding what they're agreeing to, and it could be harmful to continue with the exam at that point. The other area that this can really get tough is when the patient has a mental illness, which, as you know, there's a whole, again, spectrum of mental illnesses, and some wouldn't impact someone's ability to understand what this exam entails and decide whether or not they want the exam or parts of the exam. And and the other side of the spectrum is that it could hugely impact that patient's ability. There is no one size fits all answer to this. Just know that this is a conversation that the SANE may be having with the provider or the care team, and also with the patient, to make sure that they are not acting against the best wishes or against the wishes of that patient. Now, capacity consent can also change. So personally, I have done exams before where I started off and the patient absolutely knew what we were doing, but perhaps had taken some pain medication or anti-anxiety medication, or just had been up for way too many hours straight and became less able to consent as the exam went on. And the worst example of this that I had was a woman who started falling asleep during the speculum exam that she had asked for. And so the way that I handled it was to gently wake her up a couple times, keep checking back in. She continued to say she wanted it, but at a certain point when it became clear that she could not stay awake, it did not feel safe or trauma-informed for me to continue that speculum exam. So instead, I had a new conversation with her, kind of assessing kind of her new expectations and desires, and we were able to find a compromise where she still felt like she was getting the care she wanted, but I was not doing a speculum exam on an unconscious patient, which is just not defensible in any way. This can also go the opposite way, where I have also come to patients' bedsides before when they were, asleep, could not stay awake, or again, maybe under the influence of alcohol and or drugs, which they may have taken willingly or not. But in either case, they were not able to consent to the exam right away. That should never mean that they lose their ability to get the exam at all. But what it might mean is that I, as the SANE, may have to talk with them about, hey, I need to wait to to have this conversation with you and do this exam until you're a little bit more awake. And then I'll tell, their care team as well at the hospital, hey, please call me back, in a couple of hours when the patient is awake if they still want this. It's an important line between following the patient's wishes and not overstepping them as well. So we call that informed consent. It's the patient consenting to the exam with full information about what that means, what the risks are, and what the benefits are. There's another term that you might hear in the hospital that I just want you to have a passing awareness of, which is implied consent. What implied consent refers to is emergency medical care, like care that may change whether the patient survives or not, or whether their organs continue to function and they maintain the use of their limbs. When a patient comes in unconscious to the ER, but there's something life-threatening or incredibly serious like that, it is implied that they are giving consent to have the care that will save their life, even though they can't open their eyes and say, yes, please, I'm bleeding out, please give me some blood right now. So that's a term that's used in the emergency department. And I highlight it here not because you need to know the real nuts and bolts of that, but just because sometimes I've seen confusion between whether implied consent applies to sexual assault medical forensic exams or not. And like I said before, the exam can be incredibly important for the patient, but it is not saving their life in that moment or preventing organ damage or limb damage. So implied consent does not apply here. It has to be informed consent, where the patient is truly making the choice to have this exam. So having said that, I want to just give you a look at what a written consent may look like and what a medical release of information may look like. You probably have similar paperwork in your agencies, and I think it can be helpful to just see what other disciplines use. So this is one example of a consent for a medical forensic exam. This isn't what everyone will look like, but this is kind of the template that we have for the state. That's kind of a good baseline. And what this consent is highlighting is who is providing the exam, and then what that exam is actually entailing. And what we recommend at the task force is that consents have separate areas for at least these three separate parts. A, the medical evaluation and treatment related to the sexual assault. So the head to toe exam, talking about medications, anything like that that doesn't include evidence collection would fall under this category. 2, a separate line of consent for evidence collection specifically, just to really highlight, that a patient can choose to have one without the other and that they're not obligated to get evidence collected just because they're seeking medical help or vice versa. And 3, that there's a separate line for photography, forensic photography, which SANEs in many facilities can take in order to preserve a photographic record of wounds or other things that may be on the patient's body. Again, I just want to highlight, the patient initialing that they give consent for medical evaluation and treatment doesn't mean that they automatically have to accept every part of medical evaluation and treatment, but it's just a nice way to check in on what at a basic level the patient wants to have done, and also for the patient to get a chance to record that clearly. Then the patient will sign, the medical provider will sign, date, and that would then be a valid consent. Then the medical release of information, this is in order to release documentation and evidence to law enforcement. Now, Rebecca mentioned the option for anonymous evidence collection here in Oregon, and we'll go over that in a little bit more depth too towards the end of this presentation. But you can see at the top here that it makes a distinction about whether this evidence is being released to law enforcement for investigation because the patient is reporting to law enforcement, or for storage, where it's not going to be released with any identifying information on behalf of the patient. It's being released to law enforcement anonymously for them to store until such time as the patient comes forward to make a report, if they ever wish to. A really important thing about the release of information is it needs to specify who is releasing the information and to whom it's being released. Release of information should not be so vague that hospitals can give out this to anyone. It needs to really specify. And then the other important thing is that it's, release of information needs to be time limited in some way. Typically, it's like 180 days, like 6 months is kind of the maximum time period, or the patient can specify a different date, often shorter. But if the release of information is past its expiration date, then a new release of information will have to be sought by the patient. And so again, this is just to make sure that this isn't used too broadly for what the patient intended, but is really leaving the power and control over this release of information in the hands of the patient themselves. And again, patient signs, medical provider signs, and then date. So since I mentioned photographs, let's just touch on that briefly as well. And before I talk about photographs, I'm actually going to talk about bodygrams, which is the way that SANEs document injuries. And so bodygrams are just these kind of outlines of human bodies or parts of human bodies in the SANE chart, where the SANE can document any wounds or anything abnormal on the patient's body that they're seeing. Typically, this means that they will draw the wound, they'll describe it, like the color, the size, the look of it. They'll do a pain assessment, describe the shape, things like that. And that is really the best way for patient injuries to be documented in the chart. They're incredibly useful if the patient ever needs medical follow-up for those wounds, or if there's investigation, it's really useful for that as well. Now, in many facilities, not all, there's also the option for photographs. And photographs, the SANE should not be replacing bodygrams with photographs. So don't be surprised if you see a SANE drawing injuries and then also taking pictures. That is normal. And it's in fact what's recommended in order to not lose important information that the patient may need medically or forensically. Now with photographs, a couple of things I just want you to be, again, generally aware of is that the SANE should still be preserving the patient's privacy. I think many patients, at least that I've met, come in with a fear that they're going to just be made to like strip naked and then just have these photos taken of them standing there. And that is absolutely not what happens, because that's not trauma informed or survivor centric in any way. Instead, what the SANE will likely do is cover up the parts of their body that are not being photographed, photograph specific wounds from a variety of distances, and then move to the next wound. And the other thing that SANEs will typically not do is take sensitive photographs. So like of genitalia or breasts or other areas that the patient may find sensitive. That's because these photographs could be subpoenaed if an investigation goes forward and if it ends up in court. And we just know it's not typically in our patient's best interest to have those photographs blown up large on a courtroom screen. So instead, we tend to rely on those bodygrams and the injury documentation for anything around the genital area or other areas of the patient's body that they feel sensitive about. But for other areas, you know, typically arms, legs, sometimes face, people feel more comfortable with, that's more likely where photographs will be taken. Again, totally up to the patient if they choose to have this done, if they only want it done for certain areas, or if they don't want it done at all. All of that is valid and all of that should be respected. Whew, hold on. So another area that the patient has lots of different options is in having evidence collected. And so we're going to talk a little bit about what that looks like. First of all, physical evidence can come in many different forms. Typically, physical evidence that a SANE might be interested in collecting would be anything where the assailant's DNA might be found. So that might be on the patient's clothing. It could be on their body, and so on or in their body, in which case swabs could be taken. One thing I want to mention there is that it's also sometimes an option for patients to collect their own swabs if they don't feel comfortable with the SANE collecting it. It's again one of those situations where it may end up being less invasive for the patient. It also may mean that the quality of evidence collected may be less, but the patient should have the ability to choose, what they prioritize in there, and the SANE should have a more in-depth discussion with them if that's something they're interested in. Physical evidence can also be things like the patient's blood and urine, mostly because, like I mentioned, if the patient was drugged or given alcohol in order to facilitate the assault, blood and urine is where that would show up. So that may again also be an option for evidence collection. Hair is sometimes collected as well, typically because if the assailant's hair is going to be used as evidence, then the patient's hair needs to be collected as well so that the crime lab can distinguish whose hair is whose. You'd be amazed how different the hairs just on your head all look. Typically, the crime lab needs at least like 20 hairs in order to establish what the patient's hair looks like. So just a little fun fact that you can throw out at a cocktail party. And then things like condoms or pads or tampons or adult diapers, things like that, may also retain evidence from the assailant. And this can be true sometimes, even if, for example, if a patient puts on a pad a couple of days after an assault, or let's say the day after an assault. If they have evidence in their vagina that is draining through gravity, even though that pad wasn't put on until after the assault, it may actually have evidence from the assault itself. And so again, SANES will kind of discuss all of those with the patient, and then they're trained in how to collect that physical evidence in a way that best preserves it. Something to know is that when clothing is collected as physical evidence, it typically is not going to be something that the patient gets back. And that's because the crime lab is very thorough. That's part of their job. And that clothing will probably be destroyed in the process of being tested. This is, again, something that the SANE should be talking about with the patient, but I just wanted you to be aware as well. Because if that means that the patient doesn't want to give up that clothing, that should, again, be honored. We all know that certain items of clothing can be very expensive. They can be tied to, emotional memories or relationships. They can sometimes change our feeling of safety in walking around. Maybe a piece of clothing reflects a person's gender identity, and without it, they may be unsafe. Maybe it's their only pair of jeans, and so losing that would be pretty catastrophic. Maybe it's a really expensive bra. Maybe it's their partner's sweater that they borrowed. A whole host of reasons that people may not be willing to give up clothing. In that case, again, SANES do have some backup options for trying to collect evidence off of clothing. Not as thorough, but again, if that is the difference between the patient being able to hold on to that piece of clothing that they otherwise are not willing to give up, then that's important and that should be respected. Oftentimes patients want to know how to best preserve any physical evidence that might be on their body. And this may be something that you get asked about if a patient is reaching out to you before they come into a healthcare environment, or if you're meeting them in a healthcare context, but the SANE hasn't arrived yet. And so I just want to touch on a few different aspects here. First of all, like I touched on earlier, time frame is important. Typically, after 5 days, physical evidence isn't left on the patient's body. It may be left on clothing from the time of the assault, or if they happen to hang on to a condom or a pad or something. But typically, it's not useful to collect physical evidence after more than 5 days after an assault. But up to the discretion of the SANE, they can talk about that with the patient. Eating and drinking may remove physical evidence that's available in the mouth. Changing clothes may remove physical evidence that's on the body because it may fall off or be rubbed off in process of changing clothes. Voiding, so peeing or defecating, pooping, can also remove evidence from the genital area. And voiding could also remove evidence that might be in the urine. And then bathing or douching can again also remove evidence that's on or inside the body. Now, all that said, the patient should never be made to feel like they can't do any of these things if they really need to do it. Again, I think that trauma-informed care is for the patient to be informed about what their choices will mean for them, but it should also be supporting their choices when they make them. So if they like absolutely need to bathe because they just feel awful after the assault, I would hate for anyone to make that patient feel like, well, you ruined your chance at evidence. Because the other point I want to make is that none of these things it's not a one size fits all situation again. None of these things is going to take a perfect evidence situation and then make it impossible. It's more like all of these things erode at the chance of getting physical evidence, but also all of these things kind of take place on a spectrum. You know, some people drink like a tiny sip that goes straight down. Some people like really just swish things around their mouth. That's going to be different in how that affects evidence in the mouth. Some people bathe really thoroughly, every nook and cranny, scrubbing hard. Some people just kind of like rub a washcloth a few places. And again, that's going to look different in how that affects any possible evidence on the body. And so even if the patient has done one or two or all of these activities, having evidence collected within the time frame should still be open to them, because there's always the chance that something stuck around. I remember hearing from a colleague once that they saw a patient who had been sexually assaulted, and the assailant actually made her shower afterwards because he wanted his DNA off of her body. And so she showered, he like made her shower pretty thoroughly. And then it turned out that she actually had some of his DNA present around her ankles because the water had washed it down, but she had managed to avoid kind of washing that area. So again, the SANE should have ideas on like how to maximize any evidence that may still remain. And so again, that's something that the SANE can talk about with the patient. The last thing I want to mention in regards to this also is that typically there are ways to like mitigate the effects of any of these also. So if the patient is in the hospital and the SANE just arrived and they're so hungry and thirsty, but they also know that they might have physical evidence inside their mouth, encourage the patient to talk with the SANE about that. Because what I would do as the SANE in that situation, and what most SANEs I know would do, is we would talk with the patient and go, hey, do you want me to collect some swabs from your mouth first? And then you can eat or drink. You don't have to worry about that affecting evidence collection. And then we can go back through the rest of this process. And many patients will say yes to that. If they need to pee before the patient arrives, maybe that can be collected in a specimen cup and then left at the bedside. Again, you don't need to memorize each of those workarounds. Just be aware that they exist. And again, if you get a chance to support the patient in speaking up for their needs, know that there are ways that we can work with them so that their needs are met. And if that means that they have a need to do something that may contaminate physical evidence or destroy it, but they also have the need to collect physical evidence, we may find ways to balance both of those needs.
I think as an advocate, you can simply remember the things that the survivor may have told you before the SANE arrives and just make sure that gets mentioned as soon as possible, which is just, you know, either the survivor's really hoping to eat as quickly as possible, just a heads up, you know, maybe you could talk about ways to work around that rather than trying to remember like, oh, can we do the mouth swabs first? You know, or something like that. Yeah.
Yeah, that's a great way to handle it. So real quick, I also want to talk about SAM's track, which, as we mentioned at the very beginning in that alphabet soup slide, is the name of Oregon's Safe Kit tracking website. And it's run through the Oregon State Police because they also run the forensic laboratory. And this is something that medical and investigative personnel should be contributing to, so that if a patient has a safe kit collected, they're able to follow on their own the path of this kit and what's being done. And so this is the website that the patient would go to. The SANE should cover it with them. But where you may come in is that because the SANE often, it is a very user-friendly website, in my opinion, because all you need to do is go to this website, trackit.osp.oregon.gov, and enter a safe kit number. And what happens when you do that is something like this screen will show up, where it'll show the safe kit number, which isn't here, that it was transferred to the forensic lab. This would be only for a reporting patient. That it was then returned to law enforcement from the forensic lab, and that testing is all complete. And as you can see, each step changes color on here, and the date that each activity was completed is also retained on here. And there's a phone number where the patient can get more information. Now, what's I think is really great about this system is it has absolutely no identifying information for the patient on here. It doesn't say what was collected in the kit. It doesn't say the patient's name, birthday, medical record number, any of it. So what that means is that this website doesn't need any login information, because the only way that you're going to be able to understand what it's saying or have it mean anything to you is if you know who that kit belongs to, which should only be the patient, anyone they choose to share it with, and then possibly folks who are involved in the kit, such as the crime lab and law enforcement. And so this allows the patient to just check up on this whenever they want, and also be able to reach out for questions if they have any. So I also want to touch on financial resources here that may be available to patients. First of which is the Sexual Assault Victims Emergency Medical Response Fund, or the SAVE Fund. So this is managed by Oregon Department of Justice through their Crime Victims and Survivors Services Division. Try to say that 5 times fast. And it is available to anyone who was sexually in the past week. It doesn't matter where they're originally from, if they're visiting from out of state or if they live here. It doesn't matter if they have insurance or not. It doesn't matter if they're reporting to police or not. As long as they were sexually assaulted within the borders of Oregon and it was within the past 7 days, this fund is available to them. Now, if they were assaulted in a different state, they would need to access the equivalent or similar fund in that state. And every state should have one. I believe it was a VAWA requirement, but we'll connect the patient with the SAVE Fund. It's accessed by just filling out it's like a quick 2-page application that the SANE will typically do with the patient. And I'll tell you what happens to that in a little bit. But what it covers is any sexual assault related care at the patient's healthcare visit. I'm going to say that again. That was a mess. So what this fund covers is the cost of a medical visit that the patient is seeking out after a sexual assault for any medical care that they received during that visit related to the sexual assault. Now, there are a few different parts in there. If the patient is seeking out any services that aren't related to the sexual assault, for example, if they were waiting in the ER waiting room for a while and now they need a dose of their blood pressure medication and they didn't bring it with them, that dose of the blood pressure medication is not going to be covered by the SAVE Fund. But it is going to cover the cost of the SANE's exam, those one-time preventative medications that we talked about, including the emergency contraception. If there are lab tests or x-rays that are related to the sexual assault, those are now covered by the SAVE Fund as well, which is fairly new. That wasn't always the case. But again, what isn't covered are things outside of the visit. So prescriptions or follow-up visits, those things won't be covered. And that's just important for the SANE to talk about with the patient. Again, you don't need to memorize those details. Just be aware that maybe you might have to encourage the patient to speak up if they have questions, just to make sure that they're truly making informed decisions. Now, after the patient fills out that application with the SANE will then get that application to the hospital's billing department, and the billing department takes care of it from there. They send it to the Save Fund coordinator, whose information I'll give you on the next slide, and she processes all that and takes care of it. So anything that is included in the Save Fund reimbursement, which will go, the Save Fund will reimburse the hospital for the services that were covered. And the hospital can't take any remaining charges from those services and pass it on to the patient. So basically, if the hospital is getting reimbursed for anything under the Save Fund, the patient should. Now, any services that aren't covered by the Save Fund, that the hospital may bill the patient for, and we'll talk about that in a second too. Now, mistakes happen. So if a patient receives a bill that they shouldn't, I wish it never happened, but it definitely does. And it can be very stressful for patients. So I want you to know, oh, I forgot that there's an extra slide in here, which is there's a survivor website where they can go for information, has some frequently asked questions, and then the medical providers page has the application form, which the SANE should also have. But if the patient receives a bill that they shouldn't have, or if they just have questions, they can always reach out to Valerie Smith, who is the Save Fund coordinator. And I really cannot speak highly enough about Valerie. She's incredibly patient-centered. She's so friendly and sweet to work with. She really wants to maximize how this can help patients who have experienced a sexual assault. So if there's an accidental bill or questions, I included both of her emails right there. There's one that's specifically for her, and then there's one for the position. So if she ever steps down as the Save Fund coordinator, A, that will be a sad day, but B, I'm sure whatever wonderful person replaces her will continue to use that save@doj.state.or.us address. The other reason that someone might want to contact her is for the last thing that the Save Fund covers, which I didn't mention yet because it's kind of a weird exception, which is that the Save Fund will cover 5 counseling sessions by any licensed mental health provider for the patient. It's something where the patient can see whoever they want as long as they're licensed. But the tricky thing about this is that the hospital technically has up to a year from the date of the visit to send in the Save Fund application to Valerie. And she then turns it around pretty quickly. But the hospitals, some are really fast and some aren't so much. And to get that information on how to get those counseling sessions covered, that's something that Valerie will need to reach out to the patient to just help guide them through that process and give them the information they need. So if the hospital hasn't sent in the form yet, the survivor may be waiting to start their counseling sessions until they hear from Valerie, but maybe Valerie hasn't received that application yet. In that case, Valerie's also asked us to pass on that they're absolutely free to reach out to her, and she will go ahead and help them set up that process before that application arrives. And then she will connect all the dots on the back end once that application is sent in. Again, she's really patient-centered and she doesn't want someone's mental health follow-up to be delayed because of hospital bureaucracy. So that also, holds for you. Please feel free to reach out to her. Please let survivors know that they're welcome to reach out to her. And just remember, if they were assaulted in a state other than Oregon, there will be a similar parallel process, but it won't be this exact one.
Let's talk a little bit about crime victims compensation. This is also managed by the Crime Victims and Survivors Services Division, CVSSD, at the Department of Justice. And to be eligible for crime victims compensation, you do have to report the crime. And so that is important to remember. And so if somebody does not want to report the crime, like Nicole said, they are still eligible for those counseling sessions. And it's, separate from CBC, but at the same time, it's very much linked to that resource. So a lot of you as advocates have probably gone through the certification process to be linked to applying for CBC, which gives you a code that you can help expedite an application for someone you're working with. It does need to be signed by the actual person who it is often, you can do it a myriad of ways. You can actually apply for it online. You can apply for it on paper with an advocate, and then you can go directly to the DOJ website. So the previous slide had a website link to the Save Fund, and so that same website will get you to there'll be a different page that will be about CBC. So another great resource for applying for CBC is your local district attorney victims assistance program. So either at the victims assistance program or at the community-based program, that's how you can get to the application itself. The application is available in both English and Spanish, so depending on the preferred language of the person who experienced the crime, it can be easier for them to access in their language. CBC is really meant to give a resource after a crime to maximize safety, and so it can be used for like we've already talked about, mental health counseling. It could be medical or hospital expenses. It could even be things like, if the survivor wears glasses and those glasses got broken during the assault, it could pay to replace the glasses or anything like that. Hearing aids, any, dentures or anything like that. And this isn't just for sexual assault, this is for any crime at all. And so if for some crimes it actually can also pay for family members to receive things like counseling. So for example, children who have witnessed domestic violence, or if it's a homicide, the family members of the homicide victim. And so it's a pretty helpful resource. And the survivor needs to spend it, and they have 3 years to spend it, so it can take some time. And there's a pretty, I think the maximum is $47,000. So it can be a lot of money that can support somebody after this crime has occurred. So it's definitely something to share with a survivor. But again, the survivor does need to report the crime to receive access or to get access to CBC.
And there is one exception for the requirement to report to law enforcement that I do want to mention real quick, which is that the requirement to report to law enforcement to access CBC may be waived for good cause. And one of the options for satisfying, for lack of a better word, good cause is to get a sexual assault medical forensic exam. So I think this may be a fairly new development, I'm not sure. But if a sexual assault patient does go through the sexual assault medical forensic exam and does not want to report to law enforcement, they will still have options to connect with crime victims compensation as well. Medication companies are also something that the SANE may connect the patient with in order to help offset some medical fees. So in particular, that HIV preventative medication regimen can be pretty expensive for folks. And because it is a prescription and it's not all given at the time of the exam, typically, that does depend a little bit on the program, it can be prohibitively expensive. So SANEs are trained to access patient assistance programs through these 3 medication companies in order to offset the costs, or rather to cover the costs of HIV preventatives for their patients. So you don't need to know all the details on that again, but I do want you to know that those exist, and that that the SANE should be offering that as an option for patients who may need it. In addition, everyone's health insurance covers different things. So there have been times where I have called a patient's health insurance to ask whether something was covered. Sometimes private insurance in particular may cover things like the HIV medication, or if there are any other outstanding costs from the exam. Oregon Health Plan also, again, there's some different tiers there. But just know that if the patient is, no, let me rephrase that. But just know that health insurance may cover some of these costs, even if it doesn't fall under, one of the things that we've already discussed. Now, something to keep in mind is that not all patients will be comfortable having charges on their health insurance, possibly because maybe they have health insurance through a spouse or a parent that they don't want to know about the assault. And I'm going to talk about that in a couple of slides. So just wanted to let you know. But before that, just want to also let you know that hospitals may choose to write off a bill for any of the services that a patient incurred during a visit after sexual assault that wasn't covered elsewhere. It really differs by hospital. So some hospitals will work really hard to make sure that sexual assault patients see absolutely not a single dime on a bill from them. Others will kind of nickel and dime and charge for everything that isn't technically covered elsewhere. That may just be something where the patient needs some support and some help around that. I wish there was like a easy, quick guide to that. Well, I wish it just didn't happen in general. I think sexual assault patients should never see a bill, but no one put me in charge of the world yet. So we're working on it. So just know that may be an area where the patient needs support. But for minors, if they need vaccines, like if there's a possibility of like hepatitis B or C transmission, something like that, or HPV is another vaccine that may protect against some of the risks from a sexual assault. The Vaccines for Children program, which I've given you the website for, is another thing that might be available for folks, and that's through the CDC. So I mentioned that privacy can be an issue sometimes in regards to this. We're going to talk about the insurance piece, but first I just want to circle back to the law enforcement reporting options that we already mentioned and just really reinforce that just like with the medical options, just like with really any of the options we've discussed, the patient has a variety of available paths open to them. Some patients know that they want to report to police and that they want evidence collected in order to help with that investigation. Maybe they've reported before they even come into healthcare and that's already taken care of. Maybe the police were the ones who let them know that they could come to the hospital. I've also seen patients who want to make a report but came into the hospital first, and I, as the SANE, can absolutely help make that report and facilitate that. Ideally, maybe even having an officer come to the hospital while they're there for my exam to minimize just how many different people they have to go see and how many different places they have to go to. Patients can also report but then not have evidence collected. The investigation may not be as strong, but again, that's something that they should be able to make a choice on. And for some folks, that will be the right choice for them. And then there's also the option not to report, but to have evidence collected anonymously. So this is a patient right, under the law, that patients can come in and have evidence collected just as if they were making a report to law enforcement. But what the SANE will do is they'll preserve the evidence the same as usual. They'll label it inside the same as usual, but then the outside of the kit and the outside of any other evidence bags won't have any identifying information for the patient. Again, no names, no birth dates, no medical record numbers, no social security numbers that shouldn't be on there anyway. And that means that the only thing identifying that evidence is the safe kit number, which is a 6-digit number. And then that number is given to the patient. And if they decide they ever want to come forward and make a report, law enforcement will hold on to that kit for at least 60 years, Again, that's pretty new as of a few years ago through something called Melissa's Law. But all the patient has to do is take that kit number in to the police agency and say, I had a kit collected, I'd like to make a report, and this was the kit number. Now, if they lose that number, they could also request their medical records from the visit, and the SANE is also recording that number in their charting for that exam. So if the patient loses that number, it's not the end of the world. They can still be connected back to it. Just that comes up. Something that's important to mention here is that the only way that evidence gets tested is if the patient is reporting the sexual assault. And that's for a few different reasons. I could wax on about it, but what it comes down to mostly is that the crime lab is run through Oregon State Police. So it just isn't feasible to put those resources towards non-reporting evidence, and also to keep that confidential. And also, the way that identifying assailant DNA works is that you take the DNA that you find, well, the forensic scientists do at least, and then they compare it against the DNA from the patient and the DNA from any other sexual partners that they may have had consensually, prior to the assault. And then once they remove those DNA profiles, they're left with the DNA profile of the assailant. That can only really be done with the cooperation of the patient and possibly, any consensual sexual partners they had. And so there's no way to do that in a responsible way that still preserves the patient's anonymity and desire not to participate in that system. So that can be hard for patients sometimes. Sometimes they want to be able to go through the testing process completely anonymously, and we simply don't have a way to do that right now. But if they have evidence collected anonymously, it will be stored, not opened, not touched, not connected to them in any way, unless they decide to come forward and make a report. And then, of course, there's the option for them not to make a report and not have evidence collected. That's totally fine too. The only other way that law enforcement may get involved is that healthcare providers, including SANEs, or healthcare professionals, I should say, including SANEs, are mandatory reporters under the law. And typically this falls into 3 different categories when it comes to sexual assault patients. Age-related is one of them. So any patient who is under the age of 18, even by a day, or any patient who is 65 and older, even if it's their 65th birthday, under the law, those are considered vulnerable age groups, and the SANE will have to make that report to law enforcement and to DHS as well. So either Child Protective Services or Adult Protective Services. There are also adults who are considered vulnerable due to disability or mental illness, and that would also be a mandatory report, again, to Adult Protective Services or APS and to law enforcement. And that's tough because, like we mentioned, disability, mental illness, both of those range so much. And so it's up to the discretion of the SANE to determine, the SANE in conjunction with the care team, to determine, was this disability or mental illness serious enough to put this patient at a higher vulnerability for the sexual assault? And if the answer is yes, it did put them at higher risk, that healthcare professional is legally obligated to report that to law enforcement and Adult Protective Services. And then the last category is a little different. If a patient comes in with a serious physical injury, like from a deadly, dangerous weapon, and that's all defined in law, but it's still kind of vague, then the injury itself has to be reported to law enforcement. It doesn't have to be reported that it was sustained in the course of a sexual assault, but the injury itself has to be reported to law enforcement. So in any of these 3 cases, law enforcement will have to be notified even if the patient doesn't want them to, which can be tough because, as we know, we really want to prioritize what the patient wants. Patient choice is like our big theme. It's so important. It's one of the keystones of this work. And we also need to follow SANEs need to follow the law of mandatory reports. And I will also say that going from a confidential advocate to a SANE, I said that the hardest thing for me was having the distraction of the charting. Second hardest thing for me was adapting to being a mandatory reporter. But SANEs should also be trained in how to continue to maximize the patient's agency. Because even though, and I've had this before, I had a 17 had to let them know that she had come in for a sexual assault. But I also let her know that that did not mean that she had to talk to them, that I was not going to pressure her to talk with them, that we did not have to do any parts of the exam that she didn't want to do because they would have access to my charting now that they were called, and just let her know this is where you still have the choice here. You can still choose to engage with them as much or as little as possible. And you can also choose to engage with me as much or as little as possible so that I don't end up making information available to them that you don't want to have available. And it was kind of a scary conversation to have, honestly, because I just really hated the fact that I was having to make this report that she didn't want me to make. But having that really open, frank conversation with her, she understood. We were able to continue our rapport, and she actually decided to continue with the exam with me, even knowing that law enforcement would be able to then put in a court order for my chart. And so that's really what I always stress to SANEs is just because you, the SANE, are obligated to make the mandatory report doesn't mean that the patient is obligated to cooperate.